My artifact this week is on lower extremity manual muscle testing. In this video, I'm going to demonstrate what manual muscle tests would be used if you had an athlete that presented with a syndesmotic ankle sprain. There are different parts of an evaluation that are used when assessing an athlete. You have your history, your observation, palpations, range of motion, strength, neurovascular, and special tests. Now this is important because manual muscle testing falls within the range of motion and the strength aspects of the evaluation. According to Jensen and Starkey, manual muscle testing is a non-invasive assessment method used to assess neuromuscular integrity and pain by relatively isolating muscles or groups of muscles. Manual muscle tests are useful in the narrowing down of special tests needed to perform based off of an initial examination and the potential differential diagnosis that the clinician develops. The importance of doing an evaluation and including manual muscle testing in it is to determine any obvious signs of trauma or deformity and determine the mechanism of injury, as well as sensations and audible clues such as potential popping or snapping and pain over the joint complex, which can provide important insights into the anatomical structures that may be injured in a patient suspected of having an ankle sprain. To give a value to the manual muscle test performed is to give a grade. Grading is an assessment of the strength or weakness of a muscle or a muscle group. Grading is based on a system in which the ability to hold the tested part in a given position against gravity establishes a grade. Grades can be used as either numerical, which goes from 0 to 5, or verbally from 0 to normal. For this artifact, I'm demonstrating the manual muscle test that will be used for a syndesmotic ankle sprain. More commonly, a syndesmotic ankle sprain is referred to as a high ankle sprain. It is a sprain to the tibiofibular syndesmosis area and the associated ligaments, such as the anterior inferior tibiofibular ligament, posterior inferior tibiofibular ligament, and the interosseous tibiofibular ligament. The range of motion includes dorsiflexion, plantar flexion, inversion, eversion, internal and external rotation. The common mechanisms of injury that occur for a syndesmotic ankle sprain include external rotation, which is the most common, hyperdorsiflexion, and also internal rotation. These occur by sharp cutting or pivoting movements, commonly on an artificial turf surface, or people will say that I rolled my ankle, which usually isn't the common term because rolling your ankle is for lower ankle sprains. Here I've listed the muscles that I am testing for a syndesmotic ankle sprain due to the fact that they are either directly affected or directly related to the action associated with the mechanism of injury. There are many muscles acting upon the foot and ankle as well, and the lower leg. I've ordered them from most affected to least affected by the mechanism of injury, and I've also included the actions associated with each muscle. So in my opinion, I believe to test for a syndesmotic ankle sprain, you include the tibialis anterior, posterior, the extensor digitorum longus, peroneus longus and brevis, tested as a group, the gastrocnemius, and the soleus. To test the tibialis anterior, you want to place one hand on the medial side of the foot and the other hand on the posterior ankle. The patient will move their ankle into dorsiflexion and eversion against my resistance, and then they will come back into neutral also against my resistance. This is your concentric and eccentric motions. I would grade her both a 4 out of 5 for both ankles. To test the tibialis posterior, place one hand on the medial foot and the other hand on the posterior ankle, but here I use the table for some stabilization. The patient moves their foot into a plantar flexion and inversion against my resistance and back into neutral against resistance. It's not a lot of force, but it's enough to make them work. I would grade her ankles both at a 4 out of 5 for each ankle. For the extensor digitorum longus, you place one hand passively extending the 2nd through the 5th digits, and the other hand should be grasping the calcaneus, except for here I use the table for stabilization. The patient plantar flexes their foot and extends the 2nd through 5th digits against resistance and then back into neutral. For her right ankle, I would grade her a 5 out of 5, and for her left ankle, I would grade her a 4 out of 5. For the peroneus longus and brevis, you test them both as a group. Place one hand on the lateral foot and the other on the posterior ankle, or use the table as stabilization. Have your patient plantar flex and evert their foot against your resistance and then go back into neutral. Now here I do have some errors, like right here, I should have had my patient come forward a little bit more. However, I would grade her both a 4 out of 5 for each ankle. For the soleus, the patient is prone with their knee flexed to 90 degrees and the ankle in dorsiflexion. For the examiner, have one hand on the plantar aspect of the foot and the other stabilizing the ankle. The patient will plantar flex against resistance and back into neutral. For my patient, I would grade them both a 5 out of 5 for each ankle. For the gastrocnemius, the patient is prone and their foot is in dorsiflexion. Have one hand on the plantar aspect of their foot and the other hand on the calf, stabilizing but not obscuring gastroc movement. Your patient plantar flexes their ankle against resistance and back into neutral. I would grade my patient a 5 out of 5 for both ankles. Some additional considerations to keep in mind is to always compare bilaterally, but make sure you compare your unaffected side on your patient first. Don't compromise the movement of the muscle that you are testing, so you need to know the actions of each muscle. Place you and your patient in a position that is comfortable for the both of you, such as, I didn't demonstrate it very well, but make sure that in the sitting and supine positions for the test, you want to have their foot off of the treatment table, their foot and their ankle. And always make sure to communicate with your patient so that way they know what actions they need to be doing and what to be expecting from each test.